Then one of the things before we begin the acute hepatitis is just to let you know, I think that this one I didn't put it. There's so much, I couldn't put everything in the slides. So clinical features of hepatobiliary diseases and their pathophysiology. So we want to look at clinical features of hepatobiliary, that is conditions of the liver and the biliary ducts, and their pathophysiology, that is how they form. For example, one of them would be jaundice. And that is one of the things that we look at when we do general exam. One of the things that we look at is jaundice, pallor, edema, all that. So jaundice is one of the things, and you know where to check, in the sclera of the eyes. And sometimes if it is severe, you can even see the yellowing of the entire skin. So basically jaundice, J-A-U-N-D-I-C-E, jaundice, J-A-U-N-D-I-C-E, jaundice. So basically it's yellow coloration of the tissues owing to bile pigment. So basically the tissues become yellow because of the accumulation of bile pigments. And what is the mechanism? How does it form? Is failure of metabolism or excretion of bile? So there's no metabolism. One of the places where metabolism occurs would be in the liver, and also that is where it will be excreted. So if you block its excretion, you end up with excessive accumulation within the tissues and within the blood. So you end up with jaundice. That is jaundice. And then bleeding, basically hemorrhage, bleeding. So generally somebody who has a liver issue, they're likely to have EC, bruising, and prolonged clotting time of blood. So if such a person gets an injury, the blood doesn't clot as fast. And the reason why this occurs, so somebody who has a liver problem are likely to develop a lot of bleeding, is because there is failure of hepatic synthesis of clotting factors. One of the functions of the liver is the synthesis of clotting factors. So if there is liver failure, you end up with failure of synthesis of clotting factors. So somebody developed, because clotting is supposed to help blood to clot. So if you don't make those clotting factors, then you're likely to have excessive bleeding. So bleeding could be one of the features of hepatobiliary disease. Another one will be edema. This the edema we'll be talking about, O-E-D-E-M-A, the swelling. And I think we talked at length about edema in subsequent, I think pathology 2, pathology 1. So basically edema, as you already know, is swelling of dependent parts owing to extracellular accumulation of water. So dependent parts are lower part of the body, for example, the feet, the places because of gravity and so on. So most of the time it will be the feet and other areas because of gravity. So there is no swelling. And the mechanism is because of failure of hepatic synthesis of albumin, resulting in reduced plasma oncotic pressure. So go back again and check at edema from pathology 1. So failure of hepatic synthesis of albumin. Albumin is one of the proteins that is important in the body. These are result in reduced plasma oncotic pressure, and you end up with edema. So if you have liver failure. Another one is ascites, A-S-C-I-T-E-S. And I think we did talk about this even before. So basically this one is fluid in peritoneal cavity. So fluid accumulate in the peritoneal cavity. Remember, peritoneal space is a potential space, but fluid can accumulate there. So fluid that is outside the intestine, that is within the peritoneal cavity, we call it ascites. And how does this happen? It's because of low serum albumin and portal hypertension. I think we'll be look at portal hypertension. Portal hypertension basically is if you have obstruction or you have problem with the liver, for example, liver cirrhosis, you end up with increased pressure within the portal vein. That's what we call portal hypertension. So slow serum albumin and portal hypertension will result in fluid, a lot of fluid getting out into the peritoneal cavity, and that will be called ascites. Another clinical feature that can occur in a scenario where we have a disease of the liver and biliary system is gynecomastia, G-Y-N-E-C-O-M-A-S-T-I. And I think we did talk about gynecomastia. Basically, enlargement of male breasts. Adult male, usually their breasts should not be enlarged. Their breasts tend to remain rudimentary, just like the one in childhood all through should remain rudimentary. But sometimes male a breast can enlarge. But of course, we are not saying all gynecomastia is not because of liver failure at all. In fact, there are still many other causes of gynecomastia. But most of the time in a scenario of liver failure, you develop gynecomastia. So basically enlarged male breast because failure to detoxify endogenous estrogen. Remember that estrogen mainly are female hormones, but they are produced in males also, but in low quantity. And usually they are metabolized or they're detoxified within the liver. Yeah. So if the liver is failed or not working optimally, then you end up with excessive accumulation of estrogens. And so that is why a male is likely to start developing enlargement of their breast, gynecomastia. Then another clinical feature that will be important is encephalopathy. Encephalopathy, ENCEPHALOPATHY, encephalopathy. You see something encephalo, it refers to the brain. So encephalopathy. So ENCEPHALOPATHY, encephalopathy. So this is basically, it may present with an altered consciousness. That is, somebody may lose consciousness, they may even go into coma, or altered consciousness. So somebody comes, maybe they are confused. So that is what we mean by altered consciousness. It can start from being confused all the way to somebody being in coma. That will be encephalopathy. And the reason is there is failure to detoxify ammonia and excitatory amino acids, which results from protein breakdown. Generally, in our bodies, there are protein breakdown, but usually these ones are taken through the liver for them to be detoxified. Yeah, ammonia, those amino acids. So if they are not detoxified, they accumulate within the blood. And so you end up with encephalopathy. Another thing, that clinical presentation that you can have, or clinical feature in a scenario where there is a problem with the liver and the biliary system, would be hematemesis. Hematemesis is HEMATEMESIS. Hematemesis. Of course, some books will spell it as HAEMATEMESIS. So mostly British English will have the HA. The American English will just put it as HE. And then we have, so basically when you talk of hematemesis, it's basically vomiting blood. And then melena, MELAENA, melena. Melena basically is passing blood in stool, and not just fresh blood, usually digested blood. So we have what we call melena stool. That is basically the stool appears dark, almost like tar. The tar is the one that we use, for example, to make our roads. So the stool will look like tar, that is black. That is what we call melena stool. And the reason for this is because there is bleeding from esophageal varices or rectally, owing to portal hypertension. So this one results usually from portal hypertension, which you end up, when you have portal hypertension, you will end up with enlargement of arteries and veins around the esophagus, we call it esophageal varices. And also around the rectum or the anal region, you are likely to have hemorrhoids, and they're likely to bleed because those vessels dilate and they're likely to bleed. And so you end up with vomiting out blood. If it is fresh blood, especially if you're having a problem with the varices, esophageal varices. And then, of course, once it is in the stool, it has become digested and will have melena stool. Yeah, so those are the clinical features of hepatobiliary diseases and their pathophysiology: jaundice, bleeding, edema, ascites, gynecomastia, encephalopathy, and then we have hematemesis or melena.